Hi, I'm Dr. Janice Morrow. Thanks for joining us for another episode of American Mood Swings, where we talk about the brain and all things related to mental health. Welcome. Hi, good evening. I'm Dr. Janice Morrow with American Mood Swings, a docu-style show where we talk about the brain and all things mental health. Tonight's topic is psychosis and schizophrenia. And I'm here, my guest tonight is Dr. Alex Kopelowicz he is the chief psychiatrist from the UCLA Olive View Medical Center, and he has a 30-year background in treating patients with psychosis and schizophrenia. He's done extensive research. So we are really thrilled to have him here with us tonight to talk about these things.
Thanks for inviting me.
All right. Well, so let's just jump right in. For people out there who have never heard of, psychosis, and let's just jump right in.
Okay. So psychosis, what we mean by that is a difficulty in reality testing. Someone can't tell the difference between what's really happening and what they think is happening. So that's the important distinction, and that can be a symptom of a lot of different conditions. One of the conditions that may be causing psychosis is schizophrenia, which is what we're going to be talking about today.
What are a couple of other things that can present? Like, because I have seen people, I've heard that when people are using methamphetamine, they can often be misdiagnosed as having, because they can have these like auditory and visual hallucinations. What are a couple of other things that can be misdiagnosed?
That's a great example. So methamphetamine can cause psychosis. They're not being misdiagnosed. They're experiencing psychosis in the sense that they can't tell what's real from what's not real. The difference is they don't have schizophrenia. In other words, the diagnosis that's causing that psychosis is not schizophrenia. It's, as you say, a substance that can mess with the mind in one way or another. There's a variety of other psychiatric conditions that can also lead to psychosis. Very severe depression. People can become morbidly depressed such that they think they're going to die right away. That's a psychosis. They could be manic. They could have bipolar disorder. And that could lead them to believe that, for example, they're Superman or they can fly or something to that effect. So it doesn't have to be schizophrenia to lead to psychosis. Believe it or not, there's actually medical conditions that can lead to it. You may have known of small children who have a fever. They may see things or hear things when they have a very high fever related to a flu, for example, and they are experiencing psychosis too. Has nothing to do with schizophrenia. It's just any sort of perturbance of the brain can sometimes lead to psychotic symptoms.
Wow, I didn't realize that so many medical things can. Let's see here. We want what is some of the diagnostic criteria? Because there's something called negative symptoms and positive symptoms. If you could differentiate between that.
Sure. So schizophrenia does consist of three different components of symptoms. We call them positive symptoms, negative symptoms, and disorganized symptoms. Let me start with positive symptoms. Positive symptoms are in no way positive. They're not good. What we mean by positive symptoms is something above and beyond normal personality. So experiencing things that most people don't. You mentioned a couple of them. Hearing things that other people don't hear. That's above and beyond normal experience. Believing things that other people don't believe. Really not culturally accepted things. Like we said before, someone's trying to hurt you, or that you have the ability to fly, or things that are, very unusual. Those are called positive symptoms because they're above and beyond normal human experience. Negative symptoms would be things that people have less than what you would expect. So a lack of motivation, a lack of energy, a lack of desire to have social relationships. Those are the negative symptoms of schizophrenia. So there are things that people do not have or have lost somewhere along the line that most other people do have. The third category is that disorganization. That's the difficulty in really kind of making sense. They're not concentrating well. They're not making sense in how they speak. One sentence may not lead to another one. So that kind of inability to really communicate with others and behave in an appropriate fashion, those would be examples of disorganized symptoms. So the three real categories we're looking for when we're diagnosing schizophrenia: positive symptoms, negative symptoms, and disorganized symptoms. Not everyone has to have all three, but very commonly people do.
Let's talk a little bit about if there's a genetic component, age of onset, and if there's different like sex differences, cultural, like as far as
the percentage, is there a country that seems to have more schizophrenic and psychotic people I'd love to hear more about some of the demographics.
Sure. Okay. So with regard to the demographics, the prevalence of schizophrenia roughly is about 1% of the population. That's true across different countries, different races, different ethnicities. So it's always more or less around 1%, more or less. So there is no evidence of any differences between different cultural groups or racial groups or anything to that effect at all. With respect to men and women, same thing. It's about the same, men versus women, in terms of the onset or having the illness. What's different is the onset. So although most people with schizophrenia develop it in their late adolescence, early adulthood, something like 18 to 25, around there are outliers where people develop it either a little earlier or a lot later. With regard to men, there's a small population that does get it in their earlier childhood, 12 to 13 years old. Much lower rates than in women and much lower than the 18 to 25, but it does happen. And then women, interestingly enough, have a second spike. So although most of them have it between 18 and 25, there's another group that has it around 50 to 55 in women. So postmenopausal. And that's led some people to speculate as to whether the loss of estrogen may have something to do with a risk factor for developing psychosis. So that's the general demographics with regard to the illness. In terms of the genetic component, because as we talked about earlier, there is both a genetic component to it as well as a stressor associated with it. How do we know about the genetic component? And it really comes from some really interesting studies that have to do with twins. As you may know, there's two different kinds of twins. There's identical twins, which we call monozygotic. That they're called identical or monozygotic because their egg and sperm fertilize, and after that fertilization, they split apart. So those two embryos are going to be identical genetically, right? Because they came from the same sperm and egg. So those are called monozygotic or identical twins. The other kind of twin is called fraternal twin. That's where one egg and one sperm fertilize, and then a separate egg and sperm fertilize in the same womb. So you're born, like there's twins that are being born at the same time, but genetically, they're just like any other brother and sister. They don't have any more connection because they're just two separate sperms and eggs. So it's important to make that distinction between identical twins and fraternal twins as I explain the rest of this story. So it turns out that across the population, as I said before, it's about 1 out of 100 people will develop schizophrenia across their lifetime. However, if you have a first-generation relative with schizophrenia, and by that I mean mother, father, sister, brother, son, or daughter, if any one of those has schizophrenia, then your risk for schizophrenia goes up to 10%, from 1% to 10%. That's a big jump, 10 times, but you're still 90% not. Okay. So that's true if you have a first-degree relative, like a fraternal twin. However, if you have a identical twin with schizophrenia, your risk for schizophrenia goes up not by 10 to 10%, but to 50%.
Wow.
So what does that tell you? Obviously, genetics matters because look at the difference between identical twins and fraternal twins. One is at 50%, the other is at 10%. But the other part of that story is it can't be all genetic because if it was, identical twins would be at 100%. If one had it, the other one necessarily would have it too, which is not the case.
Okay.
So that's the reason we think it's a combination of a genetic predisposition, who knows exactly what genes are involved, we're not really sure, and some sort of environmental stressor. As I said, that's a very generic term that means something happening to that organism. Everything from in vitro, in utero infections to obstetrical complications, to drug use as an adolescent, all of those fall under the category of stressors on the organism.
Okay. Good information. I forget the fraternal and twin information. Once somebody's diagnosed, then can talk about some of the different treatments, and I'm sure they change for the level of severity. If somebody just taking a medicine or somebody who needs to be committed, and how that goes down.
Well, obviously, commitment or being put in the hospital is the last resort. Right. So what we try to do is identify symptoms early. That's the big key in almost every illness, but particularly in psychosis, is you try to identify these illnesses as early as possible, because the longer someone goes sick, where they're having psychotic symptoms, the harder it is to treat them, just like any other illness. Imagine, for example, you had some kind of a infection. If you get antibiotics right away, you're probably going to be a lot better than if you wait 2 weeks, 3 weeks, 4 weeks before you go get treatment and your body has already gotten infected all over the place. Same is true with psychosis. The earlier you can actually identify the illness and treat it, the more likely you'll be successful. We call it the duration of untreated psychosis, or DUP. Duration of untreated psychosis. So the longer the duration of untreated psychosis, the worse the outcome. So the key is identifying these symptoms early and treating them early. Now you ask, what kind of treatments? Well, the good news is that for positive symptoms, the hallucinations, the delusions, the paranoia, they respond normally very well to a class of medications called antipsychotic medications. So we try to start people on those medications early on in the process, and most of the time they work. They really help people with psychosis. The trouble is that the other symptoms, especially negative symptoms, don't respond as well to the antipsychotic medications. We require other kinds of treatment, more psychotherapeutic approaches to improve negative symptoms in those patients who their positive symptoms are well controlled by medications.
What are a couple of the side effects? Because I know that there's people that are very scared to take medicine because, there's a couple lines of thought, like, I don't want to be on medicine forever, and I don't want these horrible side effects. But all medicine, I mean, even aspirin, everything has side effects. A lot of people don't realize that. They're slowing something down. So what are a couple of them, and how do you determine which meds to?
That's a great question. So, the medications have been around for schizophrenia since the 1950s. And the first generation of antipsychotics, unfortunately, did have a lot of side effects. The good news is about 20, 25 years ago, another generation of medications have come out that, although they still have problems, nowhere near the side effect burden of the first generation. So these second generation antipsychotic medications, while they still do have some side effects, for example, one of the most common ones that people complain about are movements, abnormal movements. They'll get some tremors, or they'll get some slowness in their ability to walk. We call them Parkinsonian symptoms because they resemble Parkinson's. They're not Parkinson's. It's got nothing to do with Parkinson's, but it looks like Parkinson's to the untrained eye. And so those kind of symptoms really worry people because, it doesn't feel good to be slowed down or have tremors or to that. As I said, most of the newer medications don't have that problem, and if you titrate the medication carefully, you can avoid the most severe of those side effects.
I had heard of the one that's used. Is it still popular? It's called clozapine.
Actually, clozapine is not that popular. It's not commonly used. I'm glad you brought that up, though, because clozapine is a very unique medication in that it has benefits for patients that nothing else works on. So it's usually saved for those individuals who nothing else has worked and they try clozapine. And in that population, we call it the treatment refractory population. They're refractory or unable to respond to the more conventionally used antipsychotics. About 30% of those people do respond to clozapine. So it's almost like a last resort antipsychotic medication, but it's an extraordinarily good medication. The problem with clozapine and why it's not used as a first-line agent, which would be your question, right? Why save this really great medication for the end? Well, it's because 1 out of 100 people who get on clozapine can develop a side effect called agranulocytosis. What that means in simple terms is your bone marrow doesn't make the blood cells, especially the white blood cells that you need to fight off infection. So because it happens to 1 out of every 100 people, a lot of people don't want to use this medication at all. What we do for those people who really need it, we do blood tests on them every single week to make sure that their white blood cells are okay. And if they are, then they're not one out of 100. If they do start showing signs of their white blood cells going down, then we take them off of clozapine.
Okay. I had heard something about drooling just from doing research, and I thought, okay, well.
Drooling is a side effect of clozapine and of other antipsychotics as well, but it's a manageable side effect. I mean, I distinguish between really bad side effects like not having a white blood count and, a nuisance like, drooling a little bit that you can handle with other medications or a little towel or whatever the case may be.
Okay, good. Well,
I don't mean to be flippant about it. It's
no.
very true that some people really are upset about the side effects, but that's my job as their doctor, is to try to talk to them about what are their concerns and how we can ameliorate some of those concerns.
I'd love to talk about a little bit about things like for a family member that if you have a loved one, because I think not having any experience with this for most people, if they haven't, and all of a sudden a family member or loved one is experiencing these things, hallucinations, delusions, like are there certain things not to say? Because in my own personal, just having a family member that's been sick, it seemed like now that we're doing the show and I'm learning from people like you, it feels like everything I would say to him was wrong. like you mentioned, fixed false beliefs. Like this person's trying to kill me, someone's in the next room, and you could say, I would say, no one's in the next room, take him to the next room, or show him physical evidence, and it didn't seem to work. No. So it almost seemed to escalate it. So are there things that what would you recommend to somebody out there watching this, like anything that you should not do?
Yeah, so it's very individualized, right? Because it really depends on the individual that you're working with and who that is. But I agree with you. Forcing people into treatment generally is not the best way to go. Really, it's trying to figure out what can you do to help this individual live their life better. So what we normally do when we counsel with families and we work with them is to say, what is it that the individual is experiencing these symptoms? What do they think is going on? And what would they like to have better in their life? If there's something that we can help them work on what their goals are, then we can introduce that. I'll give you a real typical example. So I'll have a family come to me and say, he's having voices, he's having delusions, et cetera, but he doesn't want treatment. I'll say, well, what does he think is wrong? What does he, feel like he wants help with? And they'll say, I don't know. I said, did you ever ask? So, okay, let's ask. So we'll bring the person in and talk to him, and he'll say, what bothers me more than anything else, I can't sleep at night. I'm up all night, and then I sleep during the day, and then I can't do my things. Oh, okay, that's a symptom we can target. So in other words, the reason he's up all night is because he's hearing voices or whatever, but we're not going to target that. We're going to focus on what is it that they experience as a problem, and we'll target that as the symptom that can be addressed. So, for example, I'll talk to him, so would you like some medicine to help you sleep at night? Would that be good? Yeah, I could try that. So the point is that we look at what is it that the individual wants as opposed to us coming up with some objective measure of, they're having voices, therefore they need treatment. No, they're having some negative experience that's bothering them. Let's find out how we can help.
When we were talking about medicines, well, there was two questions that just came back. So when we talked earlier on about delusions and the hallucinations, I know one general theme is that people are trying to kill them, the people that I know. But I'd like to know if there's any other common themes that you see other than people are being chased or they're trying to kill me. And then because we want to stay open. Most people want to stay open to traditional medicine, holistic, but there's a sect of people that are like, I don't want to take anything. I can handle this naturally, vitamins, herbs, breathing, meditation. And from what I've seen, like with the severe psychotic episodes and people, better to take some. I don't see the natural things working and being as effective. What are your thoughts on that? Because there are people that would think, like with depression and anxiety, they can be more effective. But I have not seen that in my own experience with severe psych. What are your thoughts on that?
Two great questions. Right. So the first question you were talking about had to do with not so much medications, right? You were wanting to know more about
simply if there's common things, because I know
in the symptoms themselves. So you think about paranoia as the most common thing, but it's not only the case. There are other delusions where people might believe that they're all powerful. Sometimes we talk about the fact somebody may believe that they're Jesus Christ. In France, you'll get a lot of people who believe that they're Napoleon. It's very culturally dependent.
For real.
Yeah.
Really
so
do.
Depending on the culture and the background, people will have different kinds of delusional ideas. And like I said, some of them are grandiose as opposed to paranoid. So it can really vary as to what somebody's delusion might be. It could even be bizarre. It could be that, this is a very common one, unfortunately, is that their parents aren't their parents. Their parents were taken over by some sort of alien being, like Invasion of the Body Snatchers kind of thing. And that person really is not their parents. It's someone who looks like their parents, but it's not them. And they'll do that for their spouses or their children or things like that. So paranoia is not the only one. It can be a variety of different delusions that can manifest themselves in psychosis.
I had forgotten about it till you just mentioned that. Why a friend of mine in college, I lived with this woman, and her son's been in a hospital for probably 30 years now. But I know that one of his beliefs, he was diagnosed with schizophrenia. is that he's been dating Marilyn Monroe, that she's his girlfriend.
Yeah.
So very interesting. And even after all this time, he still thinks that she's his girlfriend.
And we've seen quite a bit of erotomania, we call it. People who believe that someone's in love with them, and so that they have to pursue them in that kind of fashion. And that happens. That absolutely happens. We'll get those folks brought into our hospital because they've gone to someone's home that they shouldn't have gone to, and they'll get arrested.
Because they think
that they heard it on a YouTube video that they wanted.
Kim Kardashian went through his girlfriend. Okay.
I wasn't going to use any names, but
okay.
That wouldn't be an unusual one. Let's put it that way. Yeah. So that's an example of that. With regard to the treatments and natural kind of treatments, let me be really clear about this. I don't discourage people from using any kind of natural healing approach or using teas or things that help them in whatever way.
Calm down.
Right. And remember we talked about this before, is that if there's a genetic and a stress component to it, then whatever you can do to reduce the stress is a good thing. So if tea helps you, or natural herbs help you, or whatever else in terms of reducing your anxiety or whatever, that can only be good. Will it replace the use of an antipsychotic medication? Probably not. But can it help? Sure. So I don't discourage people from using them. I just try to encourage them to work with me, and maybe some of my medicines might be mixed with some of theirs, and we might be able to find a place that will help them deal with things.
I've often wondered about people. Does insurance, for the most part, do most people's, is there help for people if they don't have really good insurance, or what kind of help is there for people who need, if they weren't employed, didn't have it through their employer, and they really need antipsychotic medicine? Are there a lot of programs to help get that medicine to them?
That's where I work. So I work for the County of Los Angeles. So we're the safety net. So we take care of people that have either nothing at all, which can be some, or the grand majority of our people actually have Medicaid. In California, we call it Medi-Cal. So most people that we deal with are folks that have Medi-Cal, which is the public insurance program. And that pays for all the treatments.
Okay, good. I was curious if they have that.
Yeah, no, that's very important. In California, we do have the grand majority, and ever since Obamacare, it's expanded the number of people that have Medi-Cal. So it's been, that's not really been an issue for us.
Oh, that's so great.
Yeah. The only population that we don't cover, to be honest with you, but we'll see them anyway, are people who don't have Social Security numbers, because then they can't get Medi-Cal. But we take care of them too. People say that the knowledge that we have of the brain in 2023 is equivalent to what we knew about the heart in about 1870. Just to give you an idea, the heart is a pump. That's how it basically works, with a little bit of physiology thrown in, but it's pretty simple to figure out what it does and what goes wrong and how to do something about it. The brain is much more complicated and difficult to understand, so we don't really know. What we do know is that there are probably at least two major components to whatever the cause is for schizophrenia. And those two components are a biological vulnerability, or a tendency of developing the illness, with some sort of a stressor. And by stressor, I don't mean just stress, like something that makes you anxious, but some sort of stress on the system, on the organism. So for example, if someone has a genetic predisposition to developing this particular illness, which we don't know exactly what that genetic predisposition might be, and then they're exposed to, say, a virus in the womb while they're in utero and developing, that could precipitate the onset of such an illness. So it's always thought of as a sort of a two-hit hypothesis. The first is the predisposition, probably genetically mediated, and the second is things that happen after fertilization, anything, literally from in utero infection to gynecological complications to drug use as an adolescent. All of those stressors on a vulnerable system could lead to the first manifestation of psychosis and then the diagnosis of schizophrenia.
Good. I'm curious because marijuana is a hot topic the last few years. Federally there's movement towards making. I think it's already been moved from a Schedule 1 to Schedule 3 drug, but there's a lot of pushback. Some states are legalizing it, some states for recreational. So I would love to know, because some of the research that now that we're doing the show and I'm doing research, I've seen things that say it can be contributory, and for regular chronic users who smoke it every day or use it that it can lead to some of these psychotic symptoms. But I hadn't heard that before this last year, and I'd love to know your thoughts on it, if you've seen research that it can, or do you feel like it's safe? What are your thoughts? Unless it's too
No, it's a great question.
About legalizing it, because a lot of people still say, no, it's really bad for your brain. This is not good.
Right. And I can't comment on the overall bad for people's brains, but what I can tell you, and based on what we were just talking about, causality, if someone has a genetic vulnerability to developing psychosis or schizophrenia, then marijuana is toxic. And the reason that I say that is because we have very good literature on this. There have been quite a few studies in the last 20 years or so looking at individuals who are not quite developed schizophrenia or psychosis, but have the earliest signs. We call them prodromal symptoms, or they're at the at-risk state. In other words, they don't quite have full psychosis, but they have the inklings of it. They don't hear voices, but they hear whispers. They don't have delusional beliefs, but they have unusual beliefs, things like that. We can actually find individuals like this and follow them over time to see which of them develop psychosis and which of them don't. In other words, which ones are that symptom more benign, and they're not going to develop psychosis. Turns out, one of the best predictors of which of those groups who are having those at-risk symptoms, those prodromal symptoms, which ones actually convert to full psychosis are the ones that use marijuana. So if you happen to use marijuana and you have these at-risk symptoms, you are 4 times more likely to develop psychosis if you're a marijuana smoker than if you're not. That's pretty strong evidence. So that doesn't tell you about the legalization of marijuana per se, but it does tell you that there is a vulnerable subgroup that, if exposed to marijuana, are more likely to develop the full syndrome of schizophrenia.
What are your thoughts about it being moved from a Schedule 1 to Schedule 3 drug?
Well, again, that gets at the issue of the broader use of the medication. So I don't want to really make a comment about broader use of medications, but I do think that for this specific population, it's dangerous.
That are at high risk for psychosis.
Yep.
Another real hot, timely topic that we have here in the United States is we have weekly or almost weekly mass shootings. So I won't get too political, because our country is very divided. Yes. Half the country says, more gun control, more gun control, more gun control. And then the other half says, it's not the gun, it's the person. And, but from the research that I've seen and from talking to professionals like yourself, it seems like people with real mental illness are much more likely to be the victims of crime or hurt themselves as opposed to being the perpetrator. Exactly. But I'd love to hear your thoughts.
You're exactly right. That's exactly correct.
Is that
you are much more, as a person with a serious mental illness, you're much more likely to be the victim of a crime, including a shooting, than actually perpetrating a crime. That's absolutely correct. The other thing that's important is, even amongst those individuals who do perpetrate some crime with a gun, the chances, if they have an illness like schizophrenia, there are 2 major risk factors. 1, they're not taking medications or in treatment at all. And 2, they're comorbid substance abuse. So by far, if you are in your treatment and not using substances like methamphetamine and things like that, then your risk for violence is extraordinarily low, lower than the general population.
So most of these people out there that are under the impression that all these mass shootings are done by somebody with schizophrenia or psychosis, it could be other factors. It's just plain old rage, jealousy.
Yeah, that idea that it's all people with serious mental illness is an NRA talking point.
Okay.
That's not accurate.
Okay. Yeah, I wanted to hear your thoughts. Another very timely topic is CARES courts here in California. So last year, for people who are not aware, our governor signed legislation that people that are homeless and deemed mentally ill can be compelled into treatment. So it's been highly controversial. The National Alliance on Mental Illness supported this legislation. It's well-meaning. The goal of this legislation is to keep people that are challenged or having mental health issues out of the criminal courts. But immediately, like the day after it passed, every progressive civil rights group in the state, including the ACLU, Disability Rights California, which is the largest disability rights group in our country, filed suit, feeling that it was highly discriminatory, that there could be misdiagnoses. They wanted it to be implemented. So in a few counties as opposed to rolled out all over, and let's see how it works. But they were really concerned about people being stripped of their rights and being and they also, I guess the big point of was, at least when I spoke with Disability Rights California, is that forcing people into treatment doesn't have the best outcomes, that when they go voluntarily, or like you were talking about, what kind of things would they like to, but what are your thoughts? Because I have seen extreme example of schizophrenia, and somebody I love dearly could have ended up in the criminal courts and go to prison forever, and he had never exhibited any kind of mental illness, had an episode and could have been charged with 2 felonies. So I have mixed feelings. What are your thoughts on CARES Court?
So it's a really complicated topic because CARE Court does not exist in a vacuum. It exists within the mental health system, and it was designed to supplement a mental health system that is broken, especially in California. So let me explain. We already have a mechanism in California to hospitalize people against their will and to keep them hospitalized against their will for a long time. It's called the LPS system. So I'm not sure if you're familiar with it, but it was named after 3 assemblymen, California assemblymen from the 1960s, early 70s, Lanterman, Petrus, and Short. So that's LPS. And the law basically is the one that justifies the possibility that if someone is a danger to themselves, a danger to others, or gravely disabled, that means that they're not able to provide food, clothing, and shelter because of a mental illness. For those reasons, you can put someone on what's called a 5150, a 72-hour involuntary hold. The reason it's called the 5150 is because that's what the number of the LPS Act actually is in the California number of laws and that sort of thing. So you can put someone in the hospital against their will on a 5150 for 72 hours. Okay. For those reasons, danger to self, danger to others, grave disability. At the end of the 72 hours, you can actually put someone on a 14-day hold as part of the same LPS process.
Never heard of that.
Yeah. So that's what I'm going to tell you, this whole system, and then you'll see where CARE Court fits in a minute.
Okay.
So that's already going to go down the road of a legal decision, because during that 14-day hold, which a doctor can write that they still are meeting criteria for danger to self, danger to others, grave disability, within 3 days of that person being declared 14-day hold, there's something called a probable cause hearing, in which a hearing officer appointed by a mental health court here in Los Angeles, but anywhere in California, decides whether or not there is probable cause to maintain a person in the hospital against their will under these criteria. So this hearing officer, who's generally a lawyer, they hear the argument from the doctor's point of view and from the patient's point of view and render a decision if there's probable cause or not. If they feel there's probable cause, then it can go on to the end of the 14 days. If they feel like there's no probable cause, then the patient has a choice of either signing involuntary or leaving at that moment. Okay. That's already built in. I won't take you down all the different steps, but at the end of the 14-day, it's still possible that a doctor believes someone still needs to be in the hospital against their will. And they can put them on something called a 30-day hold, which is for grave disability. They're not able to take care of themselves. This is in place now, way before CARE Court. And once again, a hearing officer makes a decision and decides whether or not there's probable cause for a 30-day hold. Okay, so you can go all the way to 47 days, 3 plus 14 plus 30, in a hospital without very much.
I had no idea.
Right. Now, there's one more step that really is interesting. During the 30-day hold, if a doctor believes that this person is not going to reconstitute by the end of the 30 days, they can actually petition for something called a conservatorship. I'm not sure if you're familiar with that term.
I have.
Okay. So that basically means that someone, either the County of Los Angeles that has something called a public guardian, or a private person, let's say a family member of that individual, will be declared responsible for that individual and can decide for that individual where they can live, including a locked facility. So that's already in place here in California, the LPS, all the way up to a guardianship, or as we call it, conservatorship. So the stuff that the CARE Court is doing is not different than the LPS. What is considered the reason why we need a CARE Court is because sometimes the LPS conservatorship process doesn't go the way you want it to. For whatever reason, it falls apart, there's not enough resources, all sorts of things like that. So what the CARE Court, in my mind, really does is number one, it doesn't force you to go through those different steps, 3-day, 14-day, 30-day conservatorship. It allows you to go straight to a judge rendering a decision that this person should be compelled to get treatment, as opposed to being hospitalized for all that period of time, getting that conservatorship. That's the first thing. The second thing that gets overlooked is that the state wants the counties to take responsibility for these patients. So there's an ongoing discussion between the state, that is the one that is implementing these laws, and the county that has to actually carry them out, right? So many times the counties will say, hey, we weren't able to get the conservatorship on this patient, and so hands off. While the state is now saying with a care court, you can't do that anymore. A judge is going to say, you need to provide this treatment for this individual. So although it may sound like an unorthodox perspective, from my perspective, what the state is really doing is not so much compelling the patient, because that's always been there under LPS law. What they're really doing is compelling the county. And if the county doesn't provide the services that are required, they will get fined for not doing so by the state.
Wow.
That's what I think the care court's really about. Although everyone's focused on taking people's rights away, that already happens.
Yeah, most people, I certainly wasn't aware of it. This is the first time I've heard of any of these things. All I had heard about was a 72-hour hold, or that there wasn't much else until they do something, somebody does something criminal, and then they go to jail.
Nope.
So I'm thrilled to hear that they can get more help.
So in California, no, we have these laws that have been in place. As I said, the real challenge, to be honest with you, and I know the argument's all about care court versus civil liberties and all that, the real challenge is resources. There are a lot of patients who really do belong in a setting in which they can get 24-hour care. That's just the reality. In California, we used to have something on the order of 50,000 people who lived in state hospitals or other type of institutions. And now it's less than 5,000. What happened to those people? Where did they go? A lot of them got what we call trans-institutionalized. And the two institutions that they're in, the streets and the jails. So I think the state of California has dropped the ball. They should have been providing care, maybe in state hospitals or something like that. And instead, they bowed to the ideas of, let's all do the treatment in the community. For most people, that works great.
Like peer support, clubhouse.
For most people, that works great. But in schizophrenia, there is a significant subset of people who are going to be really sick, and they're not going to take their meds, and they're going to end up in and out of hospitals, in and out of jails, in and out of the streets. Those individuals is what care court is supposed to deal with.
This kind of segues into another question. So our federal government now, the U.S. Surgeon General Vivek Murthy, he's a huge advocate of more money allotted for mental health. So now, let's say a state is awarded a grant or money. For the average person, we're all, every one of us, we're Los Angeles residents. So there's homeless people everywhere, every corner, every time you get off a freeway, and it's devastating. I'm sure we all feel it in our souls and our hearts when we see this. And you wonder, what can be done? There's the argument, build more beds, let's say California was awarded $1 billion or $500 million, because you've been in the trenches. How would you like to see this money spent? And who helps our leaders decide? Does somebody like our governor? Is there a panel? Who's helping him decide, okay, we need this money? Do they come to people like you at these hospitals? I'd love to know how these decisions are made, and where you think this money, what do we just need more? What do we need?
Yeah, so more beds is like a mantra all the time. So I think we have to distinguish what kind of beds and for what purpose. Okay. So acute beds is like I was telling you where my hospital is. We stabilize people, they're there for a few weeks, and they can go back into the community, the grand majority of them. There's some people, as I said before, who are refractory and don't respond to other medications or throw them away once they're not interested in being in the hospital anymore. So those are the individuals that I believe are going to require long-term 24-hour care. That is a philosophical perspective that a lot of people don't want to swallow that. But it actually is true. There is a percentage of patients, I would suspect about 10%. And remember, schizophrenia is about 1% of the population. So if we look at California, that's a lot. So if you look at California and you take the idea that, let's say there's 40 million people here, 1%, around 400,000 people, 10% of those, maybe 40,000, we're going to need beds for about 40,000 people, maybe long term. That is the reality that many politicians don't want to hear. Have I told those politicians? Yes. I have certainly told those politicians when they ask, and I think some know, and I think some really realize, for example, the care court stuff, it's supposed to get you a door in, but who's going to actually pay for those beds on a long-term basis? That comes down to the counties. They have to decide how to allocate those resources, and there's a variety of different mechanisms that could be used. It's not just federal money. There's actually, in California, you may know, we have a very unique funding mechanism here in California. Are you aware of something called there's something called the Mental Health Services Act. It was enacted in 2005 by the voters of California. Proposition, it's actually Proposition 63, sponsored by NAMI, those exact people who, it was impressive. And sometimes people call it the millionaires tax. I'm not sure if you've heard of it that way, but it basically was the first of its kind in the country, where in California, anyone who had income above $1 million on their income tax would be taxed above and beyond regular state taxes or federal taxes. 1% above $1 million would go specifically to mental health. That's the Mental Health Services Act. And that generates a significant amount of money, because we have a lot of millionaires in California. Yeah. And it generates, I'm not sure exactly the number, but at the last one I heard was about $2 billion a year.
Wow. This was tax.
Just for mental health, targeted specifically to mental health. So I think the state has encouraged the counties to really think creatively about how to use that money, because that money doesn't go to the state. It goes to the counties to administer one by one to decide what's the best way to use that money for their services. And again, it gets a little political, but I think the state has wanted the counties to allocate some of that money for what I call 24-hour long-term care. Counties have been reluctant to do that. Sometimes they say that if you read the letter of the law, you're not supposed to use it for involuntary treatment. So there's a lot of complications, legal things that I'm not too aware of. But that, I think, is really the push and pull of what this care court's about. It's trying to push counties into using resources for these sickest individuals who really are not going to make it waiting for voluntary treatment.
Wow, it's just great to hear about these resources. And I guess it really, like you said, it comes down to the counties deciding. It does seem like we have a huge bed shortage, like you said, but you just did the number, so maybe 40,000 beds to start with. And
we have some.
How many beds do we have? Right?
Less than half of that.
Okay. I know a couple of years ago, one of my closest friends, her brother ended up he was having a psychotic episode right before Christmas, and he needed to be committed, and they said, like, they had to go somewhere 2 hours away, and it was still about a 4-hour,
right,
a 4-day wait.
Right.
He was experiencing suicidal thoughts, so she called me, like, do you know anyone? But it was, when you're in that moment and it's your family member, it's scary.
Right. I just think it's important to distinguish between acute care beds, those ones when they're 72 hours, 14 days, and the long run. We'd love to see the grand majority of patients, and it's true, the grand majority of patients don't need 24-hour, chronic care, but there is a subset that does.
Do we need more acute beds as well? Places like your facility?
I'd be the last to tell you we don't. I work in a psychiatric emergency room, so we have patients that have to stay 1 day, 2 days, 3 days waiting for a bed. So I'm not saying it's not a good idea if we had more beds available, but if you told me what's the real significant problem, it's the long-term beds. That's the one that really is problematic, because I think it's a philosophical challenge to people to accept the idea that there are some patients that are going to need that level of service. And most in California and in most of the country, they don't really want to think about that. They want to believe that not everyone will get better eventually if you just put more resources into it. Not true. There's no illness like that I know of. Some people, we try the best we can, for example, with cancer treatments, but they don't always work. And we acknowledge that.
All right. Very good information. It's just kind of go in a different direction. And then anything that you want to talk about that I haven't brought up, or I have been very involved in the Hispanic community and the cultural differences and how you reach that population. And can you talk a little bit about that program and how you came to realize, the things that you could do to reach a different, because I know around the world there's lots of cultural barriers and feelings towards. I think one of the lectures I heard you talking about that they felt like it was evil spirits, and I didn't know that people still felt that way about mental illness.
Sure.
Until I heard your lecture.
So I should back up and tell you, why would I be interested in the Hispanic population in the first place? Well, because actually I'm from a Spanish-speaking country. So I was born in Argentina. My born name was Alejandro Javier Kopelowicz. I came to this country when I was 3 years old. My mom spoke no English when we came here. And so I'm bilingual, bicultural.
Wow.
Didn't speak a lot of Spanish, other than to my parents growing up, because I grew up in Brooklyn and then in New Jersey. And we were in a little small town that no one spoke Spanish other than us. And I didn't really speak Spanish for most of my life until I came to Los Angeles to do my residency training. And then when the supervisors found out that I spoke Spanish, well, I got assigned all the Spanish-speaking people because I was working in the San Fernando Valley. And so, long story short, I worked with a lot of patients with schizophrenia who were of Latinx background and learned a lot about how they understand the illness and what their perceptions are, and was much different than what I'd been reading in the books regarding schizophrenia. So, for example, when you ask a family member, let's say of a Mexican-American background, what do you think your ill relative has? They don't say schizophrenia or psychosis. They usually say something like nervios or locura. And so nervios is sort of like what they mean by that is sort of like a weakening of the nerves, like something nervous, a nervousness and anxiety, that sort of thing. And locura is what we would translate as craziness. Craziness could be due to devil possession, could be due to drug use, could be due to just being evil in one way or another. So I sort of flippantly refer to the fact that my job when I work with families, Latinx families, is to try to say, your ill relative does not have locura, they have nervios. Because the stigma associated with nervios is nowhere near as bad as locura. That's a simple way of saying that you need to understand the culture and how they understand the illness to be able to work with them. So one of the big things that we started doing really early with my colleagues, I mentioned to you earlier, is trying to identify what are the symptoms of psychosis that you can see early on, and having some sort of a campaign in which we educate people about those symptoms so that they know to get treatment for what those things are, as opposed to attributing them to locura or devil possession or drug use. Maybe they can identify the early warning signs of psychosis and get help. And so that's what we started doing. That's what that La Clave project was all about.
Talk about the La Clave.
So La Clave is C-L-A-V-E, which means key or clue in Spanish. And so the letters, the C-L-A-V-E, stand for the symptoms of psychosis, right? So C is creencia falsa, which we would call delusions, false beliefs, right? L is lenguaje desorganizado, which means disorganized language. We were talking about earlier as one of the symptoms. And then A is alucinaciones, hallucinations, which could be either V, visual, or it could be escuchar. The E is to hear, escuchar. So the clave is a way of remembering easily a mnemonic for what are the symptoms of psychosis. And so what we did is we created a whole campaign, including, advertisements on billboards, on bus stops, and then we created a movie called La Clave the Movie, which demonstrates for this young woman who is having her first psychotic episode and how her family reacts to it. And we did it in Spanish, but we translated it into English, and it's available on a website so people can learn about it. It's called uselaclave.com. And you can go to that website and see the movie and then share it with others. And it's one of the things we try to do is to spread the information so that people know what they're dealing with and can get help early.
When you did this campaign, did you notice this? Is there any way to track the success or
yes,
with
yeah.
advertising campaigns?
What we noticed is that the more we talked about it, we talked about it with media types. So, for example, we had an episode on Telemundo and another one on Univision, two of the different channels. And the day after we did one of these episodes, there was a spike in the number of people that went to the website.
Oh,
so
wonderful.
We definitely know that. And then there was another spike, a little less one, at different clinics, especially our clinic that we work at. We noticed more phone calls coming to our clinic asking about first episode psychosis.
Oh, wonderful. What happens when they're at your clinic? Can you go through what a day would be like for somebody who's been brought in 72-hour care? What's going on?
So two different things. One is the outpatient clinic, and one is the hospital. Okay. So the hospital is in Silmar, and the clinic is in Granada Hills. So if they're coming to the clinic, it's because their symptoms are not as severe yet. They're not a danger to themselves, a danger to others, but they're having symptoms like paranoia, hallucinations, etc., and they're asking for help. And so we will get them a evaluation, both with a professional like a psychologist or a social worker, as well as with a psychiatrist to evaluate their symptoms and then come up with a treatment plan to help them. So that's on the outpatient basis. On the inpatient basis, oftentimes it's involuntary. Patients brought into the hospital either by the family, sometimes by the police, because there's something violent that might have occurred, and then we have to stabilize them. And that's where that 72-hour hold, 14-day hold process. And the same thing, we evaluate the patient, try to identify what's going on with them, see if we can come up with a treatment plan, and hopefully they'll buy into that idea.
You know, I'm so thankful that you joined us today, and there's been so much great information. We hope the viewers, if you're watching this, that you shared this with your loved ones, and we hope that you gained something from it and learned and can help you with your own life. So thank you, Dr. Kopelowicz, for being here today.
Thank you for having me.
All right.
Thanks, everybody, for joining us for another episode of American Mood Swings, where we talk about the brain and all things mental health. Hope to see you next week, and please share with your friends.